Hello all. Once again, we are back with the central nervous system, and one of the important topic is antidepressant drugs. We all aware about the depression when there is inappropriate or intense emotions are developed that are the leading cause of mental health disorder. But when we can consider that mood changes are a normal part of life, but when those changes become severe and it can impair functions of normal routine life, it may affect family, it may affect work environment, or it may affect interpersonal relationship. Then at that time the individual may be diagnosed having a mood disorder. So in this session we discuss about the mood disorders and the drugs used for it. Types of mood disorders. There are two major category of mood disorders are depression and bipolar disorder. Depression, it can be of two category, reactive. Depression, it is mainly due to stressful or some distressing circumstances which developed during our life. Or it can be endogenous or it called as a major depression. It is produced due to biochemical abnormality in a brain. If there is a deficiency of monoamine activity in the CNS, monoamines like noradrenaline or 5-HT, it is thought that due to deficiency of those monoamine, they are mainly responsible for a development of major depression. Say that person having depression, we might have a question that which type of symptoms were developed. The symptoms were basically categorized in a two category, which may affect the emotions. So the emotional symptoms like person having sadness, mental distress, low self-esteem, loss of interest, or sometimes person may having suicidal thoughts. But when we can consider that there is a depression because of deficiency of monoamines, so there may be some biological changes were developed. So those biological changes may produce like fatigue, loss of appetite, loss of libido, lack of concentration, and it may affect a sleep disturbance. Order. In this, there is a alternative episode of mania and depression. Mania is just like opposite to a depression. Symptoms like person may having elation of mood, there is over enthusiasm, there is overconfidence, and all this is also associated with the irritation and aggression to that patient. Now, when we can say that there is a deficiency of monoamine, so there is a one hypothesis behind the development of endogenous depression, and that hypothesis is monoamine hypothesis of endogenous depression. So this hypothesis suggests that depression is caused by deficiency of norepinephrine and 5-HT at certain sites in the brain, while mania results from a functional excess of this neurotransmission, and that is why it is opposite to a depression. So this hypothesis based on the ability of norepinephrine and 5-HT uptake inhibiting or monoamine oxidase inhibiting drugs. So those drugs, if they were administered, they can facilitate noradrenaline and 5-HT neurotransmission, and they can act as an effective antidepressant drug. Additionally, this hypothesis is supported that if reserpine-like drug is administered, those drugs which can inhibit the storage of norepinephrine, which causes depression, while tryptophan-like drugs which can increase the synthesis of 5-HT, that can elevate the mood. So both this thing which can support the thing that there is a deficiency of monoaminergic neurotransmitter during a depression. Therefore, it was considered that decrease in this neurotransmitter level is associated with the depression. When studies were conducted, some biological studies were conducted on a depressed patient. This monoamine hypothesis is not only supporting the evidence. Some authors have suggested that there are some additional mechanisms as well. One of them is they suggested that there is a down regulation of adrenergic and 5-HT receptor after antidepressant therapy. Second probable hypothesis is it may be because of neuroendocrine abnormalities, or it can be due to genetic transmission, or there is a decrease in a brain derived neurotrophic factors. These factors which mainly regulate the neural plasticity and neurogenesis. So if a person having depression, the concentration of BDNF were reduced, so the neurogenesis is gradually suppressed. So all these theories, different theories, they are complex, and its relationship with the antidepressant therapy is not consistent. So monoamine hypothesis serves a best to understood the action of antidepressant drug. So primarily be those drugs which are used for a treatment of depression, antidepressant drug, they basically work on the basis of monoamine hypothesis. Which are used, they are antidepressant drug. Antidepressant drugs, either they act by enhancing the monoamine level in the brain, either by inhibiting their uptake. Either suppose this is a serotonin, this is a norepinephrine. Those drugs which can inhibit the uptake mechanism or the uptake into a presynaptic node, they are helpful as an antidepressant drug. Or if we can use a certain drugs which can inhibit the metabolism of those neurotransmitters, again the synaptic level of those neurotransmitters will increase. So drugs can be like monoamine oxidase inhibitors, or the drugs like tricyclic antidepressant or selective norepinephrine, or serotonin norepinephrine reuptake inhibitor, or there is a selective serotonin reuptake inhibitors, or there are atypical antidepressant drugs. So basically all these three group of drugs, they can prevent the reuptake of norepinephrine or 5-HT, while monoamine oxidase inhibitor inhibit the metabolism of those neurotransmitters. And there are certain atypical antidepressant drugs. Those drugs, they produce their action by some different mechanism. Now we can move on to a individual group of drugs. First is monoamine oxidase inhibitor. You all must be aware that monoamine oxidase enzyme metabolize both noradrenaline as well as a 5-HT and dopamine. This enzyme exists in a two form, monoamine oxidase type A and monoamine oxidase type B. Type A is mainly selective for the 5-HT metabolism, while type B is non-selective one. So by inhibiting that enzyme, we can increase the concentration of both 5-HT and noradrenaline in a synaptic cleft. So non-selective and irreversible MAO inhibitor, they can enhance the neuronal level of both noradrenaline, 5-HT and dopamine. Their antidepressant action is developed very slowly over a weeks of treatment with the drug. So that when we can say that the onset of action of monoamine oxidase inhibitor is very slow, as well as it having prolonged duration of action, that their activity is recovers over 12 weeks of stopping the drug. So having slow onset as well as a prolonged duration of action. While they were administered, they interact with the many drugs and the food. So interaction with the food may leads to development of cheese-like reaction. So you must all aware about the what is a cheese reaction. They can also produce a side effect like orthostatic hypotension, weight gain, insomnia, and some anticholinergic effect. So here we can consider that though monoamine oxidase inhibitor, they increase the concentration of monoamine like noradrenaline and 5-HT, but they having additional side effects, as well as they can also interact with the food and certain other drugs. They are now not preferred drug for a treatment of depression. That there is a reversible inhibitor of monoamine oxidase type A. They are known as a REMA. The congener is baclobamide. It is preferred in mild to moderate depression, which is as alternative to a tricyclic antidepressant. As it is a reversible inhibitor, it is having various advantage in comparison with the non-selective one. So advantages which are associated, like they are shorter acting, monoamine oxidase activity recovers within 2 days after stopping the drug. While if we can consider a non-selective one, their activity recovers after 12 weeks of therapy. They cannot produce sedation or any cardiovascular or anticholinergic side effects. As well, they are well tolerated. There is no any interaction with the drugs and the food. So the cheese-like reaction are not produced with the REMA. Additionally, they are also indicated with other condition like social phobia or anxiety disorder. So if it is necessary to use MAO inhibitor, preferably you can go for reversible inhibitor of monoamine oxidase type A. Second group is tricyclic antidepressant. Tricyclic antidepressants have been extensively used for the treatment of depression for a few decades. Regarding their mechanism of action, we can consider that tricyclic antidepressants block the reuptake of both norepinephrine as well as they can also inhibit the reuptake of 5-HT. So inhibition of this reuptake processes by inhibiting the transport pump, specifically for a 5-HT, there is a serotonin transport pump, SERT is there, and the norepinephrine transport pump, NET is there. So that reuptake inhibition action can increase monoamine level at presynaptic terminals. So increased level can increase binding to that respective receptor, and that may increase the action. They can improve the symptoms of in case of depression. They can not only block the reuptake of this monoamine. Additionally, they can also bind to an alpha receptors, histaminergic receptor, as well as they also bind with the cholinergic receptor. So binding with the other receptors may lead to development of side effects. The congener which are there, the tricyclic antidepressant, they again further categorize in two types. Those which can predominantly block both noradrenaline and 5-HT reuptake inhibitors like imipramine, amitriptyline, trimipramine, doxepin and clomipramine. While there are certain tricyclic antidepressant that can predominantly block the norepinephrine reuptake. So congeners include disipramine, nortriptyline and roboxetine. Tricyclic antidepressant. Tricyclic antidepressant, they having various pharmacological action. Predominantly, their action is on a central nervous system. When if it is administered to a normal person, tricyclic antidepressant can produce dizziness, drowsiness and confusion as well, difficulty in thinking. While if it is administered to a depressed patient, after administration, after 2 to 3 weeks of the therapy, this drug can elevate the mood. It can patient can shows a more interest in a surrounding and the sleep pattern becomes normal. So here you can see the difference when it is administered to a normal person and what happen if it is administered to a depressed patient. So the primary action is on a central nervous system. Their action on the autonomic nervous system, as they also bind with the muscarinic receptor, they also having anticholinergic action. So various anticholinergic side effects like dry mouth, blurring of vision, and urinary retention effect were produced with the tricyclic antidepressant. The action on the cardiovascular system, that is because of blockage of alpha 1 and muscarinic receptor. They also produce postural hypotension. Regarding their pharmacokinetic parameters, they are rapidly absorbed and they are extensively bound to a plasma protein. They were metabolized by the microsomal enzyme and converted to the active metabolite. So when we can see that tricyclic antidepressant converted to that active metabolites, and this active metabolite also having a longer duration of action. So tricyclic and most of the tricyclic antidepressant, they're having a long plasma half-life, and due to that they must be administered once a day administration at night to avoid the daytime sedation. Regarding their adverse drug reaction, tricyclic antidepressant have lost their place as a first line drug for a treatment of depression. That is because of the adverse drug reaction profile of tricyclic antidepressant. They produce various adverse drug reaction like on the CNS, they produce sedation, and that sedation is because of antihistaminic effect. As well, they can also lower the seizure threshold, so they can precipitate epilepsy. Their effect on autonomic nervous system, so almost the typical anticholinergic side effect, dryness of mouth, blurring vision and urine retention. Endocrine side effects like weight gain and sexual disturbance, and their effect on the cardiovascular system, that is development of cardiac arrhythmia, that is mainly because of defect in the conduction. Regarding their interactions, they are, when we can see that uh, tricyclic antidepressant drug may interact with the various drug and produce an interaction like they are highly plasma protein, along with the highly plasma protein bound drug like phenytoin and phenylbutazone. We know that they are highly plasma protein bound drug. If they were administered along with the tricyclic antidepressant, they can displace tricyclic antidepressant from a plasma protein bound plasma protein, and they are able to produce a toxicity. Second, with monoamine oxidase inhibitor, as again both can, we can say that both are able to increase a level of monoamine, so they are likely to produce dangerous hypertensive crisis. Or tricyclic antidepressant having anticholinergic effect, so they can delay the gastric emptying and retard their own as well as the other drugs absorption. So they can reduce the absorption of other drug, and that is because of the anticholinergic effect. So when we can say that tricyclic antidepressant drug may having various limitation is that they're having various side effects and they produce interaction with the other drugs. Various antidepressant drugs have been developed. They are known as an SNRI or SSRI. So SNRI select serotonin norepinephrine reuptake inhibitor. They block the reuptake of norepinephrine and 5-HT as like as a tricyclic antidepressant. So they block uptake of both 5-HT as well as a norepinephrine. But the difference is with the tricyclic antidepressant is that they doesn't having any action on antihistaminic, anticholinergic, or any action on an alpha receptor. So those side effects which are developed because of binding with other receptor, that cannot be produced with the SNRI. So they having less side effect in comparison with the tricyclic antidepressant. Congeners like duloxetine and venlafaxine. Second one is SSRI, selective serotonin reuptake inhibitors. They, there are different congeners like fluoxetine, fluoxamine, paroxetine, depoxetine, sertraline, citalopram or acetalopram. These are the drugs. They are now considered as a first-line drug for a treatment of depression. When we can consider that what are the mechanism of action, they specifically inhibit the reuptake process of 5-HT. So serotonin reuptake is suppressed with a nerve ending by blocking the transport pump, and they can increase the level of serotonin. So the main action is only on a 5-HT reuptake mechanism. It blocks the reuptake process and nerve ending and increase concentration of 5-HT at synaptic cleft. So more and more 5-HT bind with the receptor site and it produces a action. Various advantage associated with the SSRI therapy, that SSRI are relatively safe and better acceptable, and due to that they are nowadays first line drug for a treatment of depression. Various advantages like there is a no sedation, it do not interfere with the cognitive and psychomotor function because there is a less CNS interaction. There is a no any anticholinergic side effects as well as a no any alpha adrenergic blocking effect. So there is a no postural hypotensive effect is produced, as well as there is a no seizure precipitating effect, and there is a no any effect on a cardiac conduction. So here we can see that list of advantages in comparison with the monoamine oxidase, in comparison with the tricyclic antidepressant, as well as in comparison with the SNRI. So they are considered as a first line drug for a treatment of depression. Regarding their adverse drug reaction, they produce some adverse drug reaction, GIT related anorexia, that is because of they predominantly increase the 5-HT level, and that stimulation of 5-HT receptor in a gastrointestinal tract may leads to anorexia. In a CNS may produce nervousness, insomnia and restlessness. As well, they can produce serotonin syndrome with the monoamine oxidase inhibitor. That is because of increased level of serotonin. Symptoms like agitation, delirium, and rigidity. Interactions which are produced, SSRI inhibit the enzyme cytochrome P2D3 and CYP3A4. We know that both this enzyme family is the largest cytochrome P450 enzyme family which metabolize various drugs. So inhibition of that enzyme family, there is an elevation of plasma level of tricyclic antidepressant, haloperidol, clozapam, and there are so many drugs. Their metabolism were suppressed. If their plasma level is increased, they are likely to produce various toxicity or adverse drug reaction. Individual SSRI, they are differ among their plasma among their pharmacokinetic profile. Some are longer acting because they are converted into their active metabolite, and that active metabolite also having a longer plasma half-life. So we can say that their individual SSRI are differ among their pharmacokinetic parameter as well as they will differ among their selectivity for a different condition. So this is all about the major group of antidepressant drug. Regarding the mechanism of delay in onset of antidepressant drug, this is one thing which is see that when we can start the antidepressant therapy, their actual action is started after 2 to 3 weeks of therapy. When we can say that why there is a delay in that effect. So the we can consider that drugs which can inhibit the reuptake of norepinephrine and 5-HT, they exhibit a biological lag of 2 to 3 weeks to produce a desirable clinical effect. There, uh, what we can say that even though their monoamine uptake effect produced immediately once you administered, they can block the reuptake mechanism is immediately, but their clinical effect will take time to produce, that is 2 to 3 weeks. So why there is a delay in a action? So here we can see that in this figure you can see that before a treatment with a neurotransmitter, when neurotransmitters are released, that is at pathological level, their global release level is very low, and when they are released they are able to bind with the respective receptor, as well as some of them are taken up back with the transport pump, or they can bind with the autoreceptor, presynaptic receptor. And we know that the function of presynaptic receptor is to control the release, so they can control the release as well as they can control the synthesis of neurotransmitter. So due to that inhibitory feedback mechanism, the net effect, it is abnormally low level of postsynaptic receptor activity, that is before treatment. Now, after we can start a treatment, acute treatment, within a short-term use of antidepressant drugs, that can result in an increased release of neurotransmitter at synaptic level. Here you can see that there is a more release of neurotransmitter. This causes, if more neurotransmitters were released, this causes more stimulation of this autoreceptors. If autoreceptors are more stimulated, there is a more inhibitory feedback mechanism into the release, as well as for a synthesis of neurotransmitter. So we can see that ultimate effect, net effect, is to reduce a release of initial effect of medication, though they can initially though increase it, but after some time there is a decrease level of neurotransmitter, that is because of this auto feedback mechanism. But when we can administer this drug for a longer period of time, chronic use of antidepressant therapy, that presynaptic autoreceptors which are there, now here you can see that the number of presynaptic receptors are more, but after chronic therapy the number of photoreceptors are reduced. So we can say that after chronic therapy there is a desensitization of presynaptic photoreceptor. Thus there is an inhibition of neurotransmitter synthesis as well as the exocytosis. Both the processes are reduced. If it is reduced, there is a more release of neurotransmission, and that can enhance the postsynaptic receptor activity. So here you can compare all this before treatment, what is a scenario. After acute treatment, there is a, though the level of neurotransmitter were increase, but due to auto feedback mechanism, actual clinical response is not observed. But after chronic therapy, these autoreceptors are desensitized, and that leads to increase in a level postsynaptic receptor activity, or we can say that the clinical response is increased. So a time interval is needed to downregulate or desensitize this receptor is the major contributing factor to observe the biological lag effect. So in a summary, we can say that depression is because of deficiency of monoamine like noradrenaline and 5-HT, and their activity is reduced in a central nervous system. Various drugs are used. They are all known as typical antidepressant drugs like monoamine oxidase inhibitors. They having various adverse drug reaction and various interaction. They are not preferred as an antidepressant. Second one is tricyclic antidepressant. They block the uptake of noradrenaline and 5-HT, but additionally they bind with the cholinergic receptor and other receptor and produce various side effects. SNRI, they as like as a tricyclic antidepressant, but they doesn't having anticholinergic side effects. While SSRI, they are the first line drug because they are safe, they are better acceptable without the anticholinergic or antihistaminic side effects. So this is all about the major group of antidepressant drugs. Remaining drugs like atypical antidepressant and the therapeutic uses discussed in a next session. That is all. Thank you.